So right now, literally just by standing up and listening to this, the relentless physics of gravity and your own internal abdominal pressure are triggering these microscopic chemical alarms right in your pelvic floor.
Yeah, it's happening constantly.
And according to a whole stack of new biomechanical research we're looking at, if you try to fix that resulting structural damage with, the latest multi-million dollar cosmetic lasers, you might actually be pouring gasoline on a fire.
Which is wild, right? Because we are seeing this massive collision between actual biological reality and, well, the clinical promises of the medical aesthetics industry.
Exactly. So for you listening, we are taking a deep dive today into the booming and honestly highly secretive world of vaginal rejuvenation and non-surgical tightening. And the stack of sources we've got today presents just an incredible contrast.
Oh, it's night and day.
Right. On one side, we have these beautifully designed clinic brochures promoting energy-based devices, treatments with these futuristic names like Formava, Thermiva, FemiLift. And they're all promising to reverse tissue laxity with zero downtime.
And then, literally on the other side of the desk, we have highly technical, really dense biomechanical research papers. Stuff from Standito's publications and PubMed.
Yeah, heavy science.
Right. And those are sitting right next to strict, very sobering warnings from the FDA and the UK's NICE guidelines. I mean, the gap between those two stacks of paper is vast.
It really is. So our mission today is to cut through all that noise and answer one core question. Does high intra-abdominal pressure, so the literal downward force from gravity, childbirth, or heavy lifting, dictate whether these non-surgical tightening results actually work?
Right, like are these flashy lasers basically fighting a losing battle against the raw physics of the human body?
Exactly. Okay, let's unpack this.
So to understand how a laser attempts to fix this tissue, we first really have to understand the biological battlefield. We have to look at the mechanobiology of the pelvic floor.
Right.
And at the very center of all this are the fibroblasts. These are the primary cells in your connective tissue. They live inside the uterosacral ligaments that hold your internal organs in place and, within the vaginal wall itself.
They're essentially the microscopic construction workers of the body, right?
That is a perfect way to put it, yeah. Their entire purpose is to produce the extracellular matrix, or the ECM. That's the dynamic structural scaffolding of the tissue.
And based on the Spandito's research, this scaffolding isn't just like a simple wall. It's a highly engineered blend.
Oh, absolutely. It's very complex. You have type I collagen acting as the rigid rebar for tensile strength. Then type 3 collagen provides the necessary flexibility. And finally, you've got elastin, which allows the tissue to stretch under a load and then snap back to its original shape.
Okay, so these construction workers, the fibroblasts, they're continuously monitoring and rebuilding that scaffolding based on the mechanical load they experience?
Exactly. The pelvic floor functions essentially like a suspension bridge and a hammock combined. It's constantly bearing the weight of your internal organs.
So every time you cough or, I don't know, lift a heavy box, experience rapid weight fluctuations, carry a pregnancy.
You're drastically increasing the intra-abdominal pressure, pushing down on that hammock. You are applying direct mechanical stretch to those fibroblasts.
But wait, hold on. That kind of defies basic workout logic, doesn't it?
What do you mean?
Well, if I go to the gym and lift heavy weights, that mechanical stress causes micro tears in my skeletal muscle fibers. Then my body repairs them and the muscle gets thicker and stronger. So why is the connective tissue of the pelvic floor like the only place where mechanical stretch seems to make it weaker?
That is such a good question.
Like, why wouldn't those fibroblasts just adapt and build a stronger scaffolding?
Well, that right there is the crucial distinction between skeletal muscle biology and connective tissue mechanobiology. Skeletal muscles hypertrophy under load, sure, but fibroblasts operate on a totally different signaling pathway.
Okay.
It is not just physical tearing that weakens the pelvic floor. It is actually an active chemical sabotage initiated by the cells themselves.
Chemical sabotage.
Yeah. The research actually quantified this in the lab. They tested fibroblasts under different physical loads. And when they subjected the cells to extreme mechanical strain, specifically a 5,333 microstrain load, which translates roughly to a 10 to 16% physical stretch of the tissue.
Okay, that sounds like a lot of stretch.
It is. The fibroblasts registered that extreme deformation and they basically panicked.
Wow. They literally panicked.
Yeah, they sense the stretching of their own cell membranes through these things called mechanoreceptors. Once that 5,333 microstrain threshold is crossed, the fibroblasts entirely abandon their construction duties.
You walk off the job site.
Completely. They drastically downregulate the production of type I collagen, type 3 collagen, and elastin. But the biological response actually goes a step further.
Oh no, what do they do?
To manage the extreme physical tension, the fibroblasts start releasing enzymes called matrix metalloproteinases, specifically MMP2 and MMP9.
Right, the MMPs. And these enzymes are collagenases, meaning they literally seek out and chew up the existing collagen and elastin fibers in the extracellular matrix.
Exactly. They actively destroy the scaffolding.
So for a listener who, say, spends 8 hours a day on her feet lifting boxes, or maybe someone who has chronic coughing, her body is actively digesting its own structural support in response to that pressure.
That's exactly what's happening. The physical tension turns the builders into a demolition crew.
That is wild. But we also have to look at the other side of that equation, right? Because the researchers tested a mild mechanical strain, too.
Yes, around 1,333 microstrain. And under that lighter load, the fibroblasts actually increase their collagen synthesis.
Okay, so mild stretch is actually a good thing.
Right, it promotes homeostasis. It's the necessary stimulation that tells the cells, hey, keep the tissue healthy. Extreme stretch, however, triggers that demolition sequence.
Which perfectly explains why pelvic floor physical therapy, like properly executed Kegels, is so beneficial. It provides that optimal 1,333 microstrain to keep the builders working.
Exactly. But there is a hormonal variable here that makes this even more complex.
Right, estrogen.
Yes. Estrogen acts as a vital chemical inhibitor. It actively suppresses the production of those destructive MMP enzymes.
So it keeps the demolition crew in check.
Basically, yeah. But when a woman enters menopause and her estrogen levels plummet, that critical biological brake pedal is just removed.
Oh, wow. So if you combine high continuous intra-abdominal pressure with the sudden absence of estrogen.
You create a perfect storm for tissue degradation. The demolition crew is working overtime, degrading the collagen matrix, and there is absolutely no hormonal signal telling them to stop.
And that leads to severe vaginal laxity and eventually pelvic organ prolapse.
Exactly.
Okay, so if the body is locked in this intense demolition phase because of gravity, pressure, and hormones, how on earth are these clinics claiming a 30-minute laser session can just reverse it?
That's the million-dollar question.
Right. I mean, looking at the glossy brochures for these energy-based devices, they fall into two main categories. First, you've got radiofrequency devices like Thermiva and Formiv, which use electromagnetic waves to heat the tissue.
Right.
And second, you have lasers like the CO2 Femilift or the Diva hybrid laser, which use concentrated light. And they all claim to somehow bypass this chemical sabotage and tighten the tissue.
Well, they attempt to bypass it by inducing a controlled thermal injury.
Controlled thermal injury, that sounds intense.
It is. They are basically trying to outshout the mechanical stress signals with an overwhelming thermal shock. So both the radiofrequency devices and the lasers target the vaginal mucosa and the underlying lamina propria.
Okay.
And they keep the tissue to very specific therapeutic temperatures, usually hovering right between 40 and 45 degrees Celsius.
The physics of that heat application is really fascinating because when collagen fibers hit that 40 to 45 degree threshold, the triple helix structure of the protein physically denatures.
Right, it unwinds and shrinks.
Which provides the immediate visible tissue tightening that the clinics heavily market.
Yeah, but that immediate shrinkage is really just the first phase. The much more significant biological goal is the secondary healing cascade.
What does that mean?
Well, by creating this calibrated, microscopic thermal damage, the devices intentionally trigger a localized inflammatory response.
Like setting off a flare.
Exactly. This sudden influx of inflammatory cytokines acts as a massive chemical wake-up call. The goal is to jolt the fibroblasts out of their stress-induced demolition phase and force them into an emergency repair phase.
Oh, okay.
It's a process called neocollagenesis.
Yeah.
Building brand new collagen fibers alongside neovascularization, which is the formation of new blood vessels to improve blood flow and overall tissue health.
And it isn't solely thermal energy being utilized either. One of the brochures features a device called V-Tone.
Oh, right, the EMS device.
Yeah, electrical muscle stimulation. So instead of heat, it uses an intravaginal applicator to deliver electrical currents directly to the pelvic floor muscles, forcing them to contract. It claims to trigger 17,000 supramaximal Kegel-like contractions in a single 30-minute session.
Right. So V-Tone is attempting to artificially induce that good, mild mechanical stress, the 1,333 microstrain we talked about.
By basically bypassing the brain's natural limit on muscle recruitment.
Exactly. forcing the levator muscle to contract 17,000 times. The device aims to aggressively rebuild muscle tone, pulling the tissue taut and signaling the fibroblasts to ramp up matrix production.
Okay, here's where it gets really interesting.
Oh, yeah.
If a patient has a baseline of severe structural damage from childbirth, or her lifestyle just subjects her to relentless high intra-abdominal pressure, her biology is actively releasing those enzymes that chew up collagen.
Right, the demolition crew is active.
So if her environment constantly signals her cells to tear the scaffolding down, well, turning up the cellular thermostat to 45 degrees Celsius or forcing 17,000 artificial muscle contractions actually save the building.
We really have to examine what happens when the relentless mechanics of the patient's body collide with the temporary biological override of these devices.
And there's a study that looked exactly at this, right? The Cheng study.
Yes. The retrospective clinical study by Cheng provides a highly pragmatic mechanical way to evaluate this collision, because instead of just relying on subjective patient questionnaires about how tight the tissue felt.
Which, can be biased.
Exactly. The Cheng study categorized patients by measuring their actual physical vaginal pressure strength.
And they utilized a surprisingly straightforward method compared to the multi-million-dollar lasers being tested. I mean, during the pelvic exam, the clinician simply inserts 2 fingers and asks the patient to perform a maximum voluntary contraction.
Yes, very manual. If the patient can maintain a strong, forceful squeeze on the fingers for more than 3 seconds, they're categorized as having light laxity.
Okay, and it's weaker.
If the squeeze is noticeably weak and fades after 1 to 3 seconds, that is classified as moderate laxity. And if there is barely any pressure felt to the point where it takes 3 or more fingers just to register the vaginal walls,
Oh, wow.
that is categorized as severe laxity. It is a direct physical assessment of the levator muscle's functional integrity.
So the verdict from comparing the treatment outcomes across those specific physical categories is incredibly definitive. The Cheng study concluded that non-surgical energy-based devices are only highly effective for patients with light mucosal laxity.
If we connect this to the bigger picture, we're basically talking about the difference between the wallpaper and the foundation of a house.
That's a great analogy.
Energy-based devices are exceptional at treating the wallpaper. They heat the mucosa, trigger surface neocollagenesis, improve natural moisture, and thicken the vaginal epithelium. But they absolutely cannot repair a broken foundation.
Right, because moderate to severe laxity typically indicates profound structural trauma to the levator muscle itself.
Yes.
We are talking about macroscopic avulsions, where the muscle fibers have been physically torn from the pubic bone during a difficult delivery, or where the deeper connective ligaments have been permanently overstretched beyond their elastic limit by decades of high intra-abdominal pressure.
And a surface-level thermal laser, no matter how advanced or expensive, cannot physically reach down and pull separated deep muscle fibers back together.
It just can't.
Right. For patients with moderate to severe mechanical laxity, the clinical consensus is that they require physical surgical intervention, such as an anterior or posterior colporrhaphy or a vaginoplasty. You have to manually suture the broken foundation and restore the anatomical tension.
This inherent limitation really explains the massive disconnect between the glossy clinic brochures and the regulatory reality. And, we want to impartially report exactly what the official sources state regarding this divide. We aren't taking sides here.
No, of course not. We're just looking at the facts.
Exactly, because there is a specific regulatory loophole that allows these devices to be heavily marketed in medi spas and clinics.
Yeah, the loophole lies in how medical devices are actually cleared for use. Both the CO2 lasers and the radiofrequency devices have received general 510K clearance from the FDA for specific surgical applications.
Right, like the ablation, coagulation, or cutting of abnormal cervical or vaginal tissue, they are authorized tools for destroying tissue.
However, the FDA has issued dedicated safety communications explicitly warning that these devices have never been cleared or approved for the specific indications of treating vaginal laxity, sexual dysfunction, or the colloquial term vaginal rejuvenation.
So the clinics are purchasing a tool cleared for general surgical cutting and marketing it off-label for cosmetic tightening.
Exactly. And the UK's National Institute for Health and Care Excellence, or NICE, echoes this exact regulatory caution.
Right.
Their official guidelines explicitly state that the current evidence regarding the long-term safety and efficacy of transvaginal laser therapy for conditions like stress urinary incontinence is inadequate.
Which is pretty strong language.
It is. They recommend that these specific applications should currently be restricted entirely to formal monitored research settings.
And the NICE guidelines do not merely point out a lack of efficacy data, they heavily document the actual physical risks of ignoring a patient's baseline structural damage.
Mhm.
They detail several alarming case studies where the collision between the intense thermal energy of the lasers and the patient's compromised biology resulted in some really debilitating complications.
And those case studies are crucial for understanding the worst-case scenario of that biological collision. Nice documented instances where women who were experiencing laxity or incontinence underwent laser sessions hoping for, neocollagenesis. But instead they developed severe pelvic floor hypertonus.
Wait, hypertonus. So instead of the laser relaxing and restoring the tissue, the thermal shock causes the damaged muscle to panic and lock up in a permanent, rigid spasm.
Exactly that. The intense heat from the laser provoked an extreme, continuous guarding response from the already traumatized levator antemuscle.
Oh,
Yeah,
man.
the muscle fibers clamped down to protect themselves from the thermal injury and simply refused to release.
And the NICE report details the cascading consequences of that permanent spasm. The patients experience progressively worsening dyspareunia, which is severe, sharp pain during sexual intercourse.
Right. There was one specific case study that highlighted a patient with a pre-existing history of pelvic surgeries and synthetic mesh erosion.
Oh, wow. So already very compromised tissue.
Very compromised. And after undergoing 3 laser treatments to improve her tissue quality, her pain escalated to a severely debilitating level.
Because the thermal energy reacting with her highly scarred, mechanically compromised tissue created a localized trauma response.
Exactly. It required intensive pelvic floor rehabilitation, the use of intravaginal muscle relaxants, and daily manual dilation exercises just to manage the severe muscle spasms.
It perfectly illustrates why a comprehensive physical, biomechanical assessment like, the simple finger pressure test utilized in the Cheng study is utterly vital before turning on a laser.
Absolutely vital. Exposing a pelvic floor that has sustained severe, pressure-induced structural avulsions to a massive mucosal thermal shock isn't just an ineffective treatment plan. For certain patients, it can actively and severely degrade their quality of life.
We have covered a massive amount of physiological ground today. I mean, from the mechanotransduction of microscopic fibroblasts to the physics of denaturing collagen with a 45-degree laser, all the way to the raw, relentless downward force of gravity and abdominal pressure.
It's a lot to take in.
It is. So for you, listening to this right now, understanding the hidden mechanical reality of your own body is absolutely crucial. Flashy clinic marketing, no matter how convincing the brochure is, cannot override cellular physics.
Nope. Biology always wins.
It does. Your unique daily load of intra-abdominal pressure, your specific hormonal status, and any baseline structural muscle damage you carry will entirely dictate your reality. That simple mechanical truth determines whether a $3,000 laser treatment will feel like a miraculous restoration of your tissue or a highly painful, costly disappointment. So, what does this all mean?
Well, I think it highlights a fascinating limitation in our current medical approach. Right now, we really rely on brute force. We either physically slice the tissue open and suture it during surgery, or we inflict a targeted thermal burn with a laser to force a panicked healing response.
Right, very aggressive methods.
Very aggressive. But based on the biomechanical research and how mechanical stretch dictates the fate of the pelvic floor, the future of treatment might bypass structural damage entirely.
How so?
Think about it. If intra-abdominal pressure is what forces fibroblasts to release collagen-destroying enzymes, the next frontier isn't a hotter laser. The next frontier is targeting the mechanosensors on the cell membranes themselves. Imagine a localized therapy that essentially hacks the fibroblasts, chemically blocking their ability to register mechanical stretch.
Oh, wow. So they wouldn't even know the pressure is there.
Exactly. By telling the cells to simply ignore the extreme physical tension of heavy lifting or chronic coughing, the body could maintain its structural integrity and keep producing healthy collagen. It would completely immunize the pelvic floor against the physics of daily life.
To stop the biological earthquake at the cellular level, so you never have to worry about the foundation crumbling in the first place. That is an incredible vision for the future of women's health.